All right, welcome back to Buy You Time. We always want to bring you innovative ideas, and at CIS, over the years, we've had quite a few. And I had a chance recently to sit down with Dr. Peter Fail. What were we talking about? Well, it's called the TriClip, and it's a valve repair system to treat valve disease. And TriClip is an investigational device limited by federal U.S. law to investigational use only. And we want to make sure we say that, but this was a very interesting concept on diseases that have been in the forefront, people trying to get them solved, and here in Houma, they're working hard to get that problem solved. More technology coming down the pipe.
Yeah, absolutely.
I can't wait to hear this one. Explain this a little bit, because it gets better and better every time we talk.
So we started doing mitral valve intervention years ago with literally taking a clip, if you will, we call it a fancy clothespin, and working on the mitral space with some very good results, been proved in several trials. And what we started to look at was trying to use the exact same technology in the tricuspid space, or the tricuspid valve itself. What was interesting about the tricuspid valve is that for years we've almost ignored it. In fact, it's been referred to as the forgotten valve, where of all the valves that typically are dealt with both surgically and intervention, it was really the last valve in the armamentarium that we never really did anything with. And it's not until we start looking at large data sets that we realize that people with severe tricuspid regurgitation actually did very poorly. And so we sort of take the same technology and originally use it in an off-label fashion, and now it's part of a trial. We're actually going to look at those patients who have severe tricuspid regurgitation, use the same clothespin, if you will, or fancy clip that we have, to try to grasp together 2 leaflets or 3 leaflets, if you will, to try to reduce regurgitation.
So for a guy like me, where is the tricuspid?
So it's actually the very first valve in the heart. And so if you think about how the circulation goes through the heart, it literally comes from the venous system, or the blood that has been used up and is now in the veins, comes up into the inferior and superior vena cava, goes into the right atrium, and that first valve it hits is going to be the tricuspid valve before it goes into the right ventricle, then out to the pulmonary circuit to get oxygenated, back to the left side of the heart to then be pumped to the heart. Pumped to the body.
Why has that been so quiet? Is it just a hidden kind of valve?
No, I think the presentation is a little bit less dramatic. I think part of that is it tends to have a little bit more of a fatigue component to it, maybe lower extremity edema, maybe abdominal fullness. When it's severe, it can cause heart failure. But I think that's part of the problem. We've sort of known it for a while. We've seen it. We've never really dealt with it. And even from a surgical standpoint, when you look at isolated tricuspid valve surgery, it actually has one of the highest mortalities compared to the other 3 or 4 valves, the other 3 valves that we operate on typically. And so I think not only did we maybe ignore it, but we really never had anything that we could deal with it. Now there's some newer technologies in the catheter-based intervention arena that is now addressing tricuspid valve, where we're not doing surgery on these patients, and seem to be, so far the data is somewhat encouraging.
You call it a fancy clothespin.
That's what it looks like.
But I'm sure it's a little more expensive than a clothespin.
Yeah, it is a little bit more expensive than a clothespin. It's hard to, you know, it's what we call as a clip, and it's designed in such a way where it can grasp the leaflets individually and then close to reduce the gap between the 2 leaflets themselves. I think when we use the word clothespin, I think patients get that understanding of what I'm talking about as far as, you know, we're just doing a fancy clip.
It's a simple way to describe
exactly. And that's really the important part, is trying to describe to a patient what we're going to be doing.
Now do they have different sizes for people with different openings?
We do have different sizes. It comes in 4 different sizes, what we call an NT, which is a smaller clip, and an XT, which is a larger clip, and now we have an XTW, which is a wider clip. But it's really not based on sort of individual patient, but more on what the valve looks like. Most of these valves have tricuspid, meaning 3, have 3 leaflets, but some occasionally have 4, or even on a rare case, even 5 leaflets. And what we need to do is find the area that's leaking the most and try to bring those 2 leaflets together as best we can. It usually takes 2, sometimes even 3 clips in order to do that.
Okay. Now, who's eligible for this trial, and can they submit and then you look at it, or you got to predetermine, I guess, if they
Right,
qualify.
so they are, so a couple of things they have to do. So the first one would be, there are some entrance criteria that they have to have severe mitral regurgitation or worse, and there are actually now 5 parameters of tricuspid regurgitation. They cannot have severe pulmonary hypertension. And really what we're looking for are those patients who really have more isolated, so they can't have severe mitral and tricuspid, they can't have severe aortic stenosis and tricuspid. So they're really looking for those patients who really have tricuspid regurgitation. Now, if they have both, we can fix the other valve, whether we fix that with a TAVR valve or a mitral clip, and then come back and reevaluate them and see if they.
But you'd have to do both of them if you did it.
Typically, we couldn't do them together. So
Okay.
the trial would mandate that we just focus totally on the tricuspid. All the other stuff would have to be dealt with before they can get into the trial itself.
What's the clip made out of? How big is it? I mean,
Oh, it's tiny. It's about that big. So it's
Okay.
tiny, and it's made out of, I believe, titanium and nickel and several different metals. And then it has a cover on the outside, which is like a polymer, so that actually would attract blood cells so that it will endothelialize or skin over. And it has 2 graspers in it that actually grasp the leaflets
And
themselves.
how does the valve actually work, or how do you correct it?
Well, typically what I tell my patients is that, when you were a kid and you broke your finger or you sprained your finger, you'd go to the doctor's office and he would splint one finger to the other finger as a splint. He'd use one finger as a splint. And we're literally doing the same thing. We're using 2 leaflets together, and we're using one leaflet almost as a splint for the other one. And as we bring them together, they're not allowed to either be separated and or prolapse in a way that we can bring them together.
Right. How long does the trial last?
Well, what we're trying, so the trial lasts until we get a defined number of patients that the study's designed for, and then you always expect some fallout or lack of follow-up. So we're going to go for several hundred patients that we go, not us individually in our center, but several centers around the country. Once we get a certain number of patients, then the Data Safety Monitoring Committee will look at the data and determine if we have enough and we need to go on, or can we stop here because we feel we've met endpoints.
Okay. What are the symptoms if people are experiencing what would they qualify? Maybe?
So typically, the people who come to see us typically come us for fatigue, shortness of breath. Sometimes you'll see some big bulging veins on the neck, or they pulsate, and that's usually a good sign that they have severe tricuspid regurgitation. We typically will use that, and then if they look like they would qualify, then we start doing a battery of studies, including a transesophageal echo, a right heart catheterization, some other things to make sure that they actually qualify. That data is then sent to a screening committee, which is a committee that's independent reviewers, if you will, of the data. They're not interested in the patient, they're interested in the study and the data. And they look at the data and says, does this patient meet the criteria that has been set forth by the committee? And if they say they meet, then we put them into a randomized schema.
And then they could expect pretty normal life after that, after the clip?
If we go through the clip, I mean, that's part of what the trial is designed to look at, is what is the quality of life afterwards. I think there's, in medicine, there's always this idea that if we correct something that's wrong, people will get better. And I think that, one of the things that we need to do is to make the assumption that that's not necessarily true. And that's why we have a quality of life indicator, that so when you come in and you feel poorly, and we'll ask a series of questions to determine that, and then after the clip, we'll do the exact same number of questions to see, has there been improvement or a quality of life?
So cardiologist / engineer.
Yeah, pretty much.
I mean, it develops. Does it shock you how far medicine has come?
Oh, absolutely. I mean, I think I've been very, very fortunate to be in what's called structural heart arena, which has been with aortic mitrals, other trials that we're doing in specifically non-cardiac arena or the non-peripheral arena, and it's exploded. The things that we can do today in concert with our cardiac surgeons is just phenomenal.
But all of these, I call them wires and all, you're
Right.
probably a fancy
Sure.
name. They're very small, aren't they?
Oh, they're tiny. Yeah, they're very, very tiny.
It's almost like a filament, almost the size of a filament.
It's 0.35, so it's 30 thousandths of an inch, so it's pretty tiny.
Wow. So is all this under magnification when y'all are working?
We do probably 80%, 80, 90% of it is done with echo, and so we do it with TE at the time. You can see the clip here in this. and we can see how the clip goes in, and you get a sense there's a gripper, if you will, that actually grabs the valve, and then we can actually go under here. We can then come back up, grab the valve.
You know, I hate to say it like this, but when you're doing sheetrock and you're putting things in
Very similar, anchors.
Yeah.
Yep, exactly. And so you can see how it pulls everything together.
Yeah.
Basically, that gripper will hold the leaflet in place.
Well, that is just cool to look at. How many trials have you been involved with since you've been at CIS?
I have no idea.
You quit counting, have you?
I have no. You know, it's kind of funny that in the cath lab, that on my where I hang my lead, it says Dr. Gadget. You know, because all the trials we do. I've been in a lot of trials. Like I said, I've been very, very fortunate to be in this part of the cardiovascular arena with structural, where there's somebody come up with a new idea of how to take care of heart failure and scar in the heart and valve leakage and things like that. Mm-hmm. So I've been very fortunate that we've been able to be part of these trials.
You love this kind of stuff.
Absolutely enjoy every minute of it.
It's a passion.
It is. It is. It's a lot of fun. It's you know, I think the biggest enjoyment I get from this is seeing the patients who come back to us after we've done, you know, a procedure, and there's this dramatic improvement in heart failure. And, you know, the problem with heart failure is patients tend to feel miserable. They don't feel good. They don't breathe well. They're fatigued. And, you know, after we can do a mitral clip or a TAVR or even a tricuspid, there is this dramatic improvement in how much they feel, and that's exciting.
All right, there you have it. Very innovative procedures right here in Houma, Louisiana. CIS always on the cutting edge of those technologies. And for more, you can visit cardio.com.